live videos from Lowcarb USA 2024. We've got somebody who most of you know is not from the USA. He's from Australia, Dr. Paul Mason, a big favorite of mine in the low-carb community. So Dr. Mason actually talked today about head injury and low carb. So Dr. Mason, you're into sports medicine, you're into low carb, you're into head injury. What are your thoughts about where we are now, the challenges, and where we need to be looking to go in the future?
I guess the real problem is that in terms of head injury, it's not widely accepted by the authorities, so to speak, that concussion actually is a structural injury. Now, there is an abundance of evidence that it actually is. We go back to 1994. They actually did autopsy studies on 5 individuals who actually had significant concussive injuries, and then they subsequently died afterwards. Now, and they died of unrelated causes. And they actually did some autopsies on these subjects, and they found that the long fibre tracks through their brain, these axons, they could actually see that they'd been sheared. And that was probably one of the earliest clear cases of evidence we have that concussion actually was a structural injury. And then, but obviously, as you know, it's a diagnostic test that relies on the patient being dead.
Yeah.
It has some limitations. So then we developed some other further studies where what's called diffusion tensor imaging, which is a type of MRI, where the concept is that water molecules will tend to vibrate. But if water molecules are contained within an axon, which is like a nerve projection, then the water molecules will more vibrate parallel to the length of that axon, and they can't vibrate very much to the side because it can change by the axon. So using this technique, we can actually measure the water vibration and use that to map out the tracks, the axonal tracks in the brain. And with that imaging, we can actually see in living subjects evidence of damage, even with what we call mild traumatic brain injury, which is basically concussive episodes. And the problem is that, you know, we've got these consensus statements on concussion which are saying, oh, look, we think that concussion is a functional issue. We think that it's just a temporary disturbance in the function of the brain.
Not structural.
And not structural. We think it's just a temporary disturbance in the function. And the problem is, if we take that mindset into it, we say it's only a temporary problem, then it means that we're not worried about actually intervening, and we're just saying, well, it's only temporary, you're going to get better. Our standard model of management at the moment is we're just going to watch you get better. And we call it stages of progression. So we'll say when you're still sore, you just sit down. When your headaches have gone, you can start doing some light aerobic exercise. And we basically guide patients through these stages. But in effect, we're doing nothing. We're just watching them heal.
Yeah.
But if we understand it's a structural injury, then that actually affords us the ability to actually have some other interventions. We can actually intervene in a way that actually reduces the damage and hastens the recovery. Now, the big factor is that when you get a concussion, immediately you get that structural damage. We get the shearing, you damage neurons, but then you get what's called a second wave of injury. I'm not sure if you're familiar with the second wave.
No, I'm not. So, second wave of injury, that'd be helpful.
So basically, what's actually happening with the second wave of injury is that we get an energy deficiency within the brain. So when you get a concussion, you actually damage insulin receptors. They physically get damaged, and there's some cells in the brain, some neurons, that absolutely need insulin so they can take up glucose.
Right.
So when you damage the insulin receptor, you prevent these neurons from basically accessing their energy supply. Most people's energy supply of the brain is going to be glucose. Mm-hmm. And they have what we call an energy crisis. So that means that they can't power these ion pumps. Now, ion pumps do things like they pump sodium and chloride around, and they control the fluid balance. And if you don't have control of the fluid balance in the brain, these neurons start to swell. And then after they swell, we get something called oxidative damage. Now, oxidative damage, it's basically equivalent to rusting on metal, but it's happening in biological tissue. This oxidative damage can actually kill the neurons. So as a consequence of this starvation of energy, basically we get this insulin resistance in the brain, and certain neurons require the insulin to take up glucose. The insulin receptor's not working, they can't take up glucose, they're starved of energy, neuronal swelling because of the failure of the ion pumps, oxidative damage, neuronal death. That's called the second wave of damage. But the beautiful thing is, if the brain can't use glucose, and the question is, can it use something else? And
Yes.
I think you know the answer.
I think we do.
And that would be ketones.
Right.
So ketones can provide energy to the brain, which is not dependent on insulin. So even if your insulin receptors, be damaged, dysfunctional, what have you, well, they're still getting a good amount of energy from the ketones.
From ketones.
Now, the ketogenic diet is beautiful for this. So I've got a lot of athletes who play professional contact sports, and a lot of them are on ketogenic diets, which really means that if they suffer a concussive injury, they're going to be much less susceptible to this second wave of damage. They still get the initial shearing and so on and so forth, but they don't have the second wave. But, we also have a problem. What happens if they get a whack on the head and they're not ketogenic?
Yeah.
Well, you can start a ketogenic diet, but the literature really shows it takes about 3 to 5 days to get a therapeutic level of ketones from starting a ketogenic diet. And this second wave of damage happens within hours. And so that's when we start to think, well, perhaps we could use ketone supplementation.
Exogenous ketone.
Yeah, so medium chain triglycerides, we know that they get absorbed quite uniquely and they can boost your ketone levels. But there's a risk of something called disaster pants. I'm not sure if you're familiar with. Basically, we say they have poor gastrointestinal tolerability.
That's
so
right.
we don't want disaster pants.
Yeah.
So MCTs are sort
Coconut
of...
oil in your pants.
Yeah, I mean, it's liquid.
Right.
So what we do instead is you have ketone salts and ketone esters.
Right.
Now, they each have their relative advantages and disadvantages, which we really don't need to go through in nuanced detail. But
Right.
as a stopgap measure, taking either ketone salts or ketone esters can certainly be a reasonable measure for that initial about 4 days while it takes you to enter a level of therapeutic ketosis. Then there's something else. So we also talked about the oxidation damage. Now, you must be familiar with antioxidants.
So, just so you know, Dr. Vega and I run a channel where we look at oxidative damage to the arteries.
Perfect. So I personally believe that oxidative damage is the single most dominant mechanism in the development of atherosclerosis and a lot of chronic disease.
Oh, yeah, we do too.
I think we're on the same page there.
Absolutely.
But there's a fabulous antioxidant called N-acetylcysteine, and it has actually had a rich history of use in medicine. So, I mean, remember, I don't know, if you're a junior doctor, you have a patient come in and they've had a paracetamol overdose, and their liver is going to be cooked unless you do one thing. What's that thing? We're given an infusion of N-acetylcysteine. So it surprises a lot of people to understand that the antioxidant potential of NAC is known to mainstream medicine. It's just that they don't use it for a wide variety. But anyway, so there was a study, a randomized controlled trial. They looked at US military personnel, and they were exposed to concussive blasts via improvised explosive devices. And in one of the groups, in the intervention group, they gave them high-dose N-acetylcysteine for a week. And there was a significant reduction at 7 days in the symptoms suffered by the NAC group compared to the control group. Concussive symptoms, a significant reduction in symptoms. So,
Interesting.
So what this really speaks to is to say, even if we can't deal with the energy crisis, we can attenuate or ameliorate some of the downstream effects
Oxidative damage
of the oxidative
to the brain.
damage. Absolutely. But there's also other nutritional effects as well. So if we have a look at creatine, we often supplement it as creatine monohydrate. It's something that bodybuilders use. It's creatine.
And in America, we call it creatine.
Ah, right. Well, we're both not speaking the Queen's English. I'll just put my teeth back in here. Right. Anyway, sometimes my dentures come out. So anyway, so this chemical of which we know, by the way, aluminum or aluminium?
We make fun of aluminum.
Oh,
But we totally,
anyway.
we completely understand.
We'll agree to disagree. Let's go with that one.
Oh, and then I'll say aluminio, please.
Yeah, that's right. But then you got Jesus coming in from Mexico with a whole different pronunciation.
Yeah, well, they're Mexico. No, I was teaching the boy about the pronunciation of that last night. So anyway, we have this creatine.
Mhm. Creatinine, but
Creatinine, okay.
Say I can't remember how you said it. I don't.
It was weird, whatever it was. But this is actually, it helps regenerate ATP. ATP is the currency of energy in the body.
For sure.
And the muscles are very, this is why bodybuilders will often take creatine. But did you know that it's also in the brain? Now, not as in high quantities as in the muscle tissue, but it's still quite significant. So if you've got energetic problems as well, it's also plausible that supplementing with this could actually help with, energy supply, so on and so forth. And there was a pilot study, but it was still a randomized control trial where they had people with post-concussive symptoms, and they gave them high-dose creatine. And they found that there was a significant reduction in the symptoms of concussion, things like headaches predominantly, symptoms of dizziness, fatigue, so on and so forth. And this was hugely statistically significant. So
very interesting.
This is potentially, also when you understand that where does this chemical come from? It comes from flesh. It is completely deficient on a vegan or a vegetarian diet. You get it from fish, you get it from meat, you get it from poultry, nothing else. So they've actually, this is as a bit of an aside, but they've done randomized controlled trials that actually prove that supplementing with this actually improves the IQ.
Interesting.
But here's the question, in which population did they study? They did it in vegetarians. Now, why would they do a study like that in vegetarians and not omnivores? It's because omnivores are getting diet, they wanted to maximize their chances of actually having a finding. So what we know is that if you're not getting sufficient dietary creatine, then supplementing will make you smarter. But that's as a bit of an aside.
You're not going to use that that as an opportunity to make a comment about the plant eaters in the crowd.
Look, what we will say, people can choose whatever diet they want. There's a lot of individuality, everybody's got their choices. But at the end of the day, if I have a plant eater come in, and I see lots of patients who are vegetarian or vegans, that doesn't mean that we disregard the science. And the point is that there's certain nutrients which are not as bioavailable following a vegan or a vegetarian diet, which you will benefit from taking if you're following that kind of diet.
Right.
Now, the whole notion of when we talk about a well-balanced vegan diet, well, really well-balanced just means paying attention to your nutrients, and that means supplementing. And I think that's well accepted.
It is.
So, but I mean,
My partner's a vegan.
Well, what a lot of people probably don't appreciate is the extent of nutrients which you may need. So, I mean, B12 is the obvious one. We talk about creatine, we talk about iron, but also something like zinc, something like taurine. So it's a lot more, most people, they have visibility of B12. But it is
not so much the other
It's
ones.
quite more expensive. Or we might even talk about something like omega-3. But it's true, the plant version of omega-3 is far less bioavailable than the animal version. In actual fact, all the studies that have shown an increase in intelligence in children have studied the animal form. We take vitamin A. Well, the plant version is 12 times less bioavailable than the animal version. We have a look at iron, for example, so we know there's a big difference in absorption between heme iron and non-heme iron.
Right.
But most people don't actually realize that if you're having legumes are often promoted as a source of iron, but only about 1 to 2% of the iron from legumes can actually be absorbed. So people can eat whatever diet they want, but I think just in the interest of informed consent and of shared care, they really need to have an awareness of what nutrients are perhaps suboptimal on a particular kind of diet and take care of that.
So we're gonna have to cut the interview for a little bit because we have an emergency. You might want to take a look at this side, and you are gonna have to take care of that probably.
Oh, okay.
Yeah. So anything that you want to add, Dr. Brewer?
No, it's been a wonderful interview. Thank you so much, Paul.
No, I think just needs to go to the toilet.
Oh, okay.
Exactly.
Oh,
Yeah. No, I just. I mean, I didn't want to.
I had a little bit of a
Yeah, and just
some family needs.
We can
So
do that,
thank you so
exactly.
much. Thank you so much.
Do you want to
for-
keep chatting? Or?
Yeah, absolutely.
But I'm happy to keep chatting.
Oh yeah, no, it's wonderful for us. I mean, I just didn't want to expose
Yeah.
just the kid to the audience. Okay, good. So I cut you off. I'm
well,
sorry.
No, that's all right. I mean, depends on how hard you want to go with the vegan diet thing.
So I think you were, so.
You're dedicating this to our vegan partner in the office, right?
That's right. Well, we've got a vegan partner in the office. I've got a vegan social partner who I love very much. And, there's a lot of discussion and a lot of recognition, as you mentioned, about vitamin B12.
Yeah.
There's not so much discussion about the other micronutrients.
Yeah.
But I don't know how much further to go on that. I did want to ask you something. You're a sports medicine doc.
Yes.
So tell us a little bit more for everybody. So my group, my typical avatar on our channel is half of them are over age 55, 3/4 of them male. And I was talking with Eric Westman the other day, and it's interesting because we're talking about use of medications and things like that. And he was saying, well, my typical patient is in his 40s and with a BMI of 35 or more. My typical patient's over 55 with, I'm our avatar. BMI of 23, 22, 67 years old. So it's a very different group in terms of what's the best exercise? What should we be focused on?
Okay.
Exercise is a big part of what we talk about when we're talking about our patients.
So I think there's patterns of exercise. So you know this whole thing where we say exercise 30 minutes a day, 5 days a week, 2 days off? Mm-hmm. That is not based on science. You know how we got to that recommendation?
Probably.
Group of experts sitting around in a room saying, what are we going to do? Okay, everybody should exercise every day. Or excuse me, I don't think everybody wants to exercise every day. That's a bit unrealistic. Why don't we give them a couple of days off? Chorus around there. But the point is, this is groupthink. This is consensus, and it's not absolutely based on science. Our exercise guidelines are pretty much nonsense. Yeah. And understand, my official title is a sports and exercise medicine physician. Mm. But what is very good is high intensity exercise. And I think this is underappreciated. And I think even when we get cautious as doctors about, if I tell somebody to go on exercise, they might have a heart attack and they might faint or something like that. So we have to be a little bit judicious about doctors. We call it CYA medicine.
Yes.
Which is,
cover your backside.
Cover your backside medicine.
Yes.
And to a large degree, the advice we give patients about, don't exercise too hard, that's more to protect us than it is to actually give the patient the best benefit, best bang for the buck. But the more intensity you exercise with, the better you are. So they did a study, this is probably getting on for almost 20 years ago now, where they had some subjects, and one group of them, they said, you're going to ride on an exercise bike, you're going to sprint for 6 minutes. You're going to sprint for 30 seconds. Then you're going to take a rest, and then you're going to do it again. And you're going to do that 4 times. You're going to do that, so you're going to exercise for 2 minutes. And you're going to do that 3 days a week. 6 days a week of total exercise. But when they're going, all out. They're sprinting hard.
They can't.
And then the other group.
They can't sing. They can't talk to somebody. No. They're just going.
They're exhausted at the end of it. They take minutes to recover.
Yeah.
The other group was exercising for an hour a day, 6 days a week. So you've got one group, 6 minutes exercise a week. Another group, 6 hours of exercise a week. Their improvements, their exercise parameters, their VO2 max, so on and so forth, were equivalent. Mm. But here's where it gets interesting. So given that you've got those results, if you went to somebody in the 6 minute group and you said, look, you've just exercised 6 minutes, you've had equivalent gains to somebody exercising for 6 hours, what exercise regimen are you going to follow in future? Can you guess what the most common response was?
Let me think. Maybe 6 minutes, huh?
No.
No. Why?
Now, why? Because people don't like working hard. Which this actually, I guess I'm a bit type A. I'm probably a bit like you. I say, I want to get it. I can get it over and done with, and time efficient. Thank you very much.
Yeah.
But I mean, that was a really fascinating sign. But
That
really,
is fascinating. I haven't seen that study.
it does speak to it, the intensity of exercise being very important. So I think compound body movements where you're using a lot of the body, and exercise has purposes too. So if I'm dealing with osteoporosis, well, what are the most common sites of osteoporotic fracture? We have the wrist, we have the vertebral column, which isn't as debilitating, and we have the hips. If you break a hip, that's not very good. So my advice is, well, maybe you want to be going up and down stairs. We want to get some loading through the hips, and if you're able to, maybe do some skipping, maybe some hopping, and it really depends on the physical aptitude of the patient. But you know, single leg hopping, nothing is going to be better to load the hip.
Yeah.
To get that mechanotherapy response. So mechanotherapy just refers to the fact when you load a bodily tissue, you'll actually encourage protein synthesis in a way that will resist that load in the future.
Right.
What do we do about a Colles fracture, a fracture of the radius? Well, we do push-ups, we do, and you can start off, we do wall push-ups. So sometimes we might come over here, so the very first one will be just coming against the wall. And then we might go down and do push-ups on the knees and then push-ups on your toes. But we want loading, we want force to be coming through the wrist.
Yeah.
You know, and if you can, if you want to put a backpack on and then, you know, do some, you know, fast walking, then you're going to get some loading through your spine. We don't want to do enough that overstresses the bones, but this kind of exercise would be very good for bone health. If you want to get an excellent cardiovascular workout, you can actually do that from resistance exercise. If you're doing a lot of compound work, you ever do a set of push-ups, you know, by the time you get to 40 or 50 push-ups, you're breathing hard because you sucked in a lot of oxygen from that. So when you do muscle exercise using enough muscles and using big muscles, that will be good. Now, legs is great. There's the biggest muscles in our body. So if you really want to, you know, suck up the oxygen and get a cardiovascular benefit as well as just a muscle building, then we do legs. But a lot of people have problems with their back. So one thing I see, I've actually got a spinal interest in my practice. My specialty is actually spinal pain. And the amount of people I see who end up, you know, going to the surgeons, I'm actually also work as an assistant neurosurgeon one day a week, and you know, the amount of patients we see on the table, and we ask them, how'd you do that? I was doing, you know, some Olympic weights or what have you. I mean, the simple fact is picking heavy stuff up from the low floor is not a good exercise for a lot of people. You can exercise your legs another way. So, I mean, there's a whole community of bro science out there saying, you know, do your deadlifts, or so on and so forth. But the reality is I see the results of that, the consequences of that. And you can exercise, so you can do step-ups if you've got a chair there. You just a single leg step-up, or if you've got a step up and over on the step, single leg on a 30 centimetre step, most people will struggle to get to 30 repetitions and their leg will be burning. So you can actually do a lot of exercises. I think step up and overs is a great one, sucks up the oxygen, works big muscle groups, cardiovascular benefit. Push-ups is another great one because you're sort of getting isometric work through your whole core and through your legs while working the big muscles across your chest and your arms. So if you just had to pick three, you know, some stepping kind of exercise would cook you out, push-ups, and then probably throw in chin-ups as well. I mean, these are compound muscle exercises that use more than one muscle at a time. If you were coming in and just doing a single bicep curl or something like that, then yeah, you build a big bicep, but so what? Yeah. You know, you're not getting the same. You can show it off. You're not getting the same. Well, we call these beach weights. We call these beach weights, and I mean, always today, you know, you walk around something like this, and we make the comment, yeah, they forgot leg day, right?
So this morning, since Jesus was here with me, we did some B-roll that we've been meaning to do.
Right.
B-roll for our YouTube channel.
Yeah.
Guess what we did in terms of the exercises?
Step-ups.
We did step-ups.
Push-ups.
We did push-ups from different angles.
Yeah.
Including, you know, putting my feet on the
bench.
Bench, and then, you know, the lower push-up.
Yeah.
We did sprints.
Perfect. High intensity.
High intensity
Good.
work. What else did we do? Step-ups, push-ups, sprints.
Some squats. Some jumping jacks just to have in the library.
Yeah.
Because you don't do those that often either.
Well, occasionally. So I have to admit I don't go to the gym very often, but I do a little bit of workout at home. And actually, I've got a little fellow over here who often helps me make the push-ups a little harder from time to time. Which works quite well.
I have a 7-year-old and she does the same to me.
How do we go with that?
There we
So,
go.
you know, a little bit of extra resistance
There you
makes
go. Look at that.
all the difference.
You're doing the hard part, right? Dad's got it easy.
But the trouble is, I've
Wonderful.
got 2 kids,
Oh, so now you get
and
the
both of
other
them get on.
Yeah.
I don't do it very often, and it's because I think it's probably going to kill me. But
Well, if it doesn't, it'll certainly make you stronger.
well, that's true. Yeah, well, that's what they say.
Yeah.
When we're talking with our patients, one of the things that's really hard to your point in your research that you quoted earlier, we get a lot of people that will do deadlifts, you know, guys wanting to do upper body stuff. We get a lot of people that just don't want to do the hip training. Now, let me ask you this. Rehit,
I beg your pardon?
reduced exertion, high intensity intervals.
Not
Have you
familiar
heard any of
with
that?
No.
So
I'm
it's fairly new, and it's got some evidence behind it. And it's a much kinder, gentler, well, not gentler, it's far more efficient. It's where people are saying you take a 20-second high-intensity phase, but instead of getting to 80 to 90%, you try to get to 100%. Only go for 20 seconds, rest for, go back to a lower intensity, a rest phase, and then do 2 of those, and you get some significant improvement. Have you ever heard of that?
I haven't, but let's talk about how exercise actually makes you stronger. So it's actually the tensile loading of the muscle. It doesn't actually matter whether you get incredibly fatigued. Now, the fatigue and the lactic acid and all that, that's important for the energy systems of the muscle. So if you're going to be doing a lot of endurance, but if you're doing strength or muscle hypertrophy, it's just tension on the muscle, and that activates what we call mechanoreceptors within the cell, which says, hey, we're under stress, we need to make more protein, so you get more protein synthesis. So I read a study, it was probably about 10 years ago, and they did it on mice, and they splintered their legs so their hamstrings were on stretch. And they found that if they splintered it with the hamstrings on enough stretch, they could actually get hypertrophy of the muscle.
Of the hamstring.
Even though it was held statically still, the mice weren't actively contracting at all. It wasn't using any energy, but it was being tensile loaded. And this is also, we know this instinctively in medicine. So if we have somebody on crutches because they've got a leg problem, we know that their hamstring is going to be relatively okay at the end of that convalescent period, but their quadricep is going to have significant atrophy. The reason is because the quadricep, when the knee is stretched, is unstretched.
Yes.
So it doesn't have any trophic stimulus on it, so it's more likely to atrophy. But the
hamstring
hamstring
is
under more
stretched.
stretch.
Right.
So when you actually think about this, so when we talk about, how hard you go to fatigue and all of that, well, technically speaking, you may not need to go to fatigue. Going to fatigue is good for the energy systems. If you want to do lots of repetitions, if you want to get that lactic burn and sort of have your body dealing with lactate and so on and so forth, then that's where the repetitions are really going to fatigue. But if you just want to build muscle, then you just need to make sure that you have a strong enough contraction to stimulate those mechanoreceptors within the muscle. Now, and that's obviously the $1 million question. Now, the problem is that if you do too many contractions, then you can cause micro trauma to the muscle. We call delayed onset muscle soreness, so on and so forth, and that will impair your recovery. So it's likely, and I think the research is still evolving on this, that for optimal muscle building, we know that you probably, after a heavy workout, for the first 24 hours, absolutely, you see this massive increase in the synthesis rate of muscle. And then that's probably elevated for possibly up to about 3 days, and then it backs off. But the biggest bulk of that is certainly within the first day. So if you were really wanting to build muscle, then you would probably, now I think this still needs to be borne out by research, but just looking at the data, it makes sense to me, the data on muscle synthesis, you'd be exercising every day, but below a threshold that's actually causing muscle membrane damage, so you're avoiding the DOMs. So we know, like, there's famous basketballers, traditionally we say don't do plyometric exercises. That's the explosive stuff where you bounce and jump.
Right.
Don't do that maybe once a week, maybe twice a week. It takes too long to recover. Well, we have elite athletes doing that every single day. Their bodies have adapted to be able to tolerate that, and with good nutrition, good genetics, and a gradual build up. The principle is called the SAID principle, specific adaptation to imposed demand. If you apply the demand, your body will adapt and you can do a bit more. So we've got these elite athletes who do plyometric exercises every single day.
I've not heard of that. That's very interesting.
Which is, completely breaks the mainstream of what we're saying. We say, oh, you only do plyometrics once or twice a week.
That's what I've always heard too.
Not for every athlete, and certainly, it depends on several factors, obviously. And you don't want to be doing it when you're sore and when you haven't fully recovered.
Interesting.
But yeah, just understanding this whole concept of mechanotherapy, I think, is underappreciated. So it's not actually the act of using ATP and contracting the muscle which provides the greatest trophic stimulus. It's just the fact that you're putting it under tensile stress.
I used to do a bit of work in Alzheimer's.
Mm-hmm.
We mentioned a couple of things that remind me of Alzheimer's tonight. One was glucose and the impact of glucose in the brain. The other was muscles and muscle activity. I don't know if you've gone into those spaces.
Well, there's a couple of... So first of all, we're now calling dementia type 3 diabetes, but basically the brain in Alzheimer's is an insulin-resistant brain. But we also know there's trophic factors that you get from exercise, so you've probably heard of brain-derived neurotrophic growth factor, BDNF.
Yeah.
Now that gets released with exercise.
Mm-hmm.
And so there's actually a direct connection between exercise and brain health, stimulating of neuroplasticity and so on and so forth.
There was a fellow, have you heard of Dale Bredesen?
I have.
So I went to one of his training weekends, and he came up afterwards and he asked me what I thought. And I said, well, it was great, but I was a little bit surprised about you didn't really cover insulin resistance except for maybe 15 minutes this whole weekend. And he said, well, and I said, well, I was being kind for the assumption that most people are not picking up insulin resistance that's out there. Over half of us have it, 90% of it's totally undiagnosed. And so I said, I would have guessed at least 50% of cases have some component of insulin resistance. And he said, oh, no, it's 100%. So then I looked at him.
So why did you not talk about it?
Why didn't you talk about it? And he got into the point about, he's more about dealing with advanced Alzheimer's. And obviously I'm more into prevention. I taught prevention in
I
Hopkins.
think that belies the point, though, because that ketogenic diets are hugely beneficial in Alzheimer's symptoms. In cognitive function absolutely improves. And I think that there are some things. So I've certainly got a lot of patients. Usually they're brought in by their family members with advanced dementia, and it is incredibly hard to control their diets. But there are low-lying fruit. There's things that you can still do, and while still, allowing them to have their sugar addiction or so on and so forth, you can make better choices. So we know that fructose, for example, is going to be worse than glucose.
Yeah.
We know, and nobody ever misses seed oils. We know that seed oils certainly make a contribution to insulin resistance. So, I promise you, if you take the seed oil out and put the butter in or put the tallow in, they're only going to thank you.
Yeah.
So there's still some things that you can do in the diet of somebody, even when they're quite deteriorated as far as dementia goes.
That's a good point. So I appreciate your time this evening and your interest and your expertise.
Well, it has been an absolute pleasure. It's been an absolute joy to meet you. I was quite excited.
Well, thank you so much. Anything else before we go?
No, well, we might see you guys next year at Lowcarb San Diego.
Well, that would be great, and maybe we'll do a. I don't know if you know, we have a channel, and it's all about helping these 52% that the CDC and NHANES know in the U.S. have diabetes or prediabetes, 18 and older. Many of us would say, no, it's more like 85%. And 90% of those folks don't know it. So that's one of the things we're doing. We would love very much to have you on the channel again to talk a little bit later.
I'd love to be there.
And you can do it from Australia, and we'll do it that way, do it digitally.
Perfect. Ever spoke to an Antipodean before?
Antipodian?
an Aussie.
Believe it or not, I have, and I still can't understand.
Well, they say we both speak the Queen's English, but I don't believe
But
a word
not
of
so.
it.
Well, just so you know, the third, the country that watches the show, the third most,
Yes.
the third
yes.
of the third of the views, a third
so
of the
if-
views comes from.
If you look at the
Australia.
Well, in that case,
geography of
g'day.
yeah, g'day. You're exactly right. If you look,
No,
sorry, say it again.
You mispronounced.
g'day.
G'day. How's that? G'day.
I think you've just lost a third of your audience.
Now you know what it feels like, Dr.
Oh,
Brewer.
it's hard. It hurts.
You don't make fun of the Mexicans, do you?
No.
Oh, good,
no.
good.
I do it myself.
I'm not
Oh,
making
right.
fun of us.
I have a thick skin, so we're good.
Yeah, Jesus and I have spent a lot of time giving each other grief.
Yeah.
But you know, some common origins. I live in Georgia and South Carolina, and you know, Georgia was a penal colony for England.
Oh, so
Australia
we've
had
got
some of that too, right?
Yeah, but it's changed a lot now.
Oh, is that right?
You don't need a criminal record anymore to go to Australia.
Oh, really? I think you still do in Georgia. Thank you again.
Fantastic.
It's been a pleasure.
Okay.